Hey there, and thank you so much for being with me today. I really appreciate that. We're a different day and a different time. I think I'm going to be moving these mini classes around a little bit and just to experiment to see how things go with that. And so thank you for your patience with the different day and time that we're working with today. You know, as we look at iridology, so many people think that all you need to do to be able to do iridology is you need to be able to look at the eyes and match one marking up with one body part, and then you're going to call that good and do an assessment from there. And that's not really how it goes. We need to understand eye anatomy in a different way than you know even a medical doctor would understand it. And so it should be, because we are looking at the eye in a different way than what a medical doctor does. By way of introduction, my name is Judith Cobb. I am a level 3 IPA certified iridology instructor. When you see here that it's got 2 years on the badge, we have to renew our credentials every 2 years. And so we get a new badge for 2 years at a time. So I've been an IPA certified instructor for longer than this by quite a bit, and an iridologist and an iridology instructor for even longer than that. I am also, I'm one of only 8 level 3 certified instructors in the world to date. And so I'm pretty pleased with having that accomplishment. I'm also a master herbalist associated with the Alberta Herbalist Association. I'm teaching at their Alberta Herb Gathering this weekend. And I am a professional member of the Canadian Association of Holistic Nutrition Professionals and the Canadian Association of Natural Nutritional Practitioners. What it really comes down to, though, is with all of this, I love teaching. I consider my one-on-one client sessions to be private tutorials for my students. And I consider these online things that I do a part of my calling in the holistic health world. Just going to plant a seed here for the dynamic iridology assessment system, which is the course that I teach in iridology. It is an IPA approved course. It covers what they consider to be level 1 and level 2. And it is the only live online fully mentored course for health professionals. I am very particular about who I teach. All of my students come to me with a college level anatomy and physiology program under their belts. So maybe you're a graduate from the Canadian School of Natural Nutrition, your A&P counts. Maybe you're a licensed massage therapist, or a licensed ND, or a licensed RN, or a licensed EMT. Those are all people who've got a college level anatomy and physiology course under their belt. Some master herbalist programs include an A&P curriculum as well. And so these are all the kinds of people that I teach, that I love teaching, because they understand eyes. They understand the body, and that's what we want. Jack Stegman is one of my, she's on the call on this show, mini class with us today. She is a graduate of my course, and she's also a certified iridologist through my course, as in she's certified with IPA because of the training that she had with me. And she says, very good iridology teacher too. Thank you, Jack. I appreciate that so much. The goal of dynamic iridology is to teach iridology, to teach you iridology so you can confidently integrate it with your herb training or your nutrition training or whatever else you have for modalities, so that you can confidently create assessments and protocols in your client sessions. This is so important. We're just going to share a few testimonials with students before we dive into what we're going to cover today. This is one of my grads. This is Joyce Lee. She is a clinical herbalist and a clinical aromatherapist. Before she took my course, she said this: I'm so excited to have this opportunity to learn new and updated iridology under Judith's expertise, under many years of experience. As a clinical aromatherapist, herbalist, and nutritional consultant, I decided to take an iridology course through another institute. I thought it would be an excellent service to add to my practice. Unfortunately, I quickly realized that I wasn't going to get the knowledge, confidence, and results I wanted, so I decided to drop it all together. Then she took the course 3 weeks in. I'm learning so much from the course so far. It's been a real eye-opener. I had no idea how little I actually knew about iridology. No wonder it was never working for me. There are many pieces to each individual's personal puzzle. The challenge is putting it all together and remembering all the little details. I love what I'm learning and appreciate your thorough teaching. After she finished the course, this is what she said. Judith is a wonderful instructor. She presents the material in this course in a concise, organized way. Every aspect of this course, of this iridology course, is covered in detail. She clearly answers every question asked, no matter how trivial the student may think it is. Judith structures the classes in a way that makes them incredibly interesting. Clarification is clearly established through her instruction, discussion, and student participation. Upon completion of Judith's course, I feel very confident in my abilities and excited to offer iridology services to my clients. This course is an incredible value, highly recommended. So the only way to enroll in the course is in a call with me, and you get onto a call by going to Dynamic Iridology, tinyurl.com, dynamic-iridology-insight. And I just need to make sure that URL is still correct. Yikes, not good, not good. Let's just see. Yes, that is still good. You can use that one. So again, if you've got the A and P under your belt already, and you're wanting to learn more about how to learn iridology, then use that link to set up a time for us to chat. All right, now, who wants to get on with looking at some eyes and some eye anatomy? If that's what you want, give me eyes in the comments box. Yeah, thanks, Jack. Appreciate that. All righty, let's see what we're looking at here. Now, Jack knows me well because she's done the course. The more you play with me in the chat box, the more you're going to get out of me. If I feel like everyone is asleep, you're going to get less out of me and we'll wrap it up early. So play with me in the chat box because that's how you're going to get what you want here. Because the first thing we want to know, and this is some of the information that I actually teach in my dynamic iridology course. This is just a segment, a little piece of one of the lessons. So, and this is great. We've got many of you saying you want to see eyes. Yes. Okay. How do you tell a right eye from a left eye? Sometimes you're working off a photograph that looks like this, where you have no distinguishing features. You don't see the nose. You don't see the inner canthus. You don't see the outer canthus. You've just got an eyeball. And so what you're looking for is the placement of the pupil. When we look at the pupil, it is never exactly in the center. Sometimes it's pretty close, but it's never exactly in the center. The narrow side names the eye. So if the narrow side is to the right of the pupil, it's a right iris. If the narrow side is to the left of the pupil, it is a left iris. And so Chana says the pupil is closer to the side it's on. Right, so narrow side names the eye. So that's the first thing you want to pay attention to. Beyond that, we want to understand the macro structure of the eye, but then we're going to look at some microstructure here as well. So we know that the eyeball is actually the nerve receptor at the end of the optic nerve. The eyeball is the largest neural receptor in our body. It has two fluid-filled chambers, one here, so we've got the cornea, and then we have the anterior chamber that is filled with aqueous humor. Then we have the iris and the lens. Then we have the posterior chamber that is filled with vitreous humor. We also, again, we're going to come back to the cornea. The cornea is clear in front of the eye, in front of the iris, and the cornea becomes opaque white, and it's called the sclera to cover the rest of the eyeball. The sclera is tough. It helps the eyeball to hold its shape, and it actually continues and wraps around the beginning portion of the optic nerve to protect the optic nerve. The sclera has blood vessels in it. The cornea does not. The pupil itself is actually a hole in the iris, and behind that hole is where the lens is sitting. How are we doing so far? Is this making sense? The optic nerve exits the back of the eyeball and it splits into two pathways. One of those pathways goes straight back. The other pathway crosses over to the opposite side of the brain. And the fact that this nerve splits and crosses is what gives us a part of what gives us depth of field for vision. Right? If we only had nerve pathways going straight back, we would only see two-dimensional. Okay, so Megan is saying she can barely hear. How's the audio for everybody else? Volume is good? Okay. Dawn says it's great. So Megan, I'm not sure how to adjust that for you. You might have two different volume settings. I know I have two different volume settings, one for my computer and one for the webinar, and they both need to be cranked up. So that might help. Sherry says it's good as well. Okay. All right. So now we want to take and look at just this part of the eye. This little tiny part of the iris. So we're flipping the eye on its back side so that we can look at this part of the iris that's sitting right here. It's important to remember that when we are looking at iridology, we're not really looking at eye health. You know, when I introduce iridology to many of my clients for the first time, they'll say, oh yeah, I was just to the eye doctor. He says my eyes are good. And I need to explain to them that I'm not looking at vision. I'm looking at genetics of how your whole body's put together. So this is one side of the iris. I want to pop back here. It's this piece of the iris right here is what we're looking at, just one side of the iris. So the pupil is here. This is the edge of the iris next to the pupil. The white of the eye is over here. Okay, is this making sense? I'm going to tell you, I looked at images like this for like 20 years and I had no idea how it related to iridology. Shannon says, I asked eye doctor once if he knew about iridology and I wish I had a picture of the look he gave me. Yeah, right. It's pretty hilarious. If they know anything, they poo-poo it, generally speaking. So as we look at the iris, the layer that is facing the world, this is the anterior border layer. This is the layer that holds the pigment. So if you've got blue eyes, you have very little pigment. If you have dark brown eyes, you have a lot of pigment. If you've got an eye that's in between, that would be what we call biliary. You've got some pigment, and that pigment is sitting right in here. When you have a lot of pigment, it hides everything else. It's like putting a thick layer of paint on top of something. So when we've got a thick layer of pigment, dark brown eyes, we don't see the rest of the structure that's in here. When we have blue eyes, we see a lot of the structure. Coming to the back side of the iris. So this is the side that's facing into the posterior, into the brain part. Into the posterior chamber. That's what it is. Do you ever have brain farts? Dang, they're embarrassing. So this faces into the posterior chamber. And the very back side of the iris is exactly 2 cell layers thick. There's only 2 layers of cells here. They are dark, dark brown or black. And they wrap around that inner edge of the iris. These are very light sensitive, and it's the light acting on or stimulating these cells that tells the sphincter muscle or the dilator muscle what they need to do. So the sphincter muscle goes around the pupil, and its job is to constrict the pupil to let less light in. If, on the other hand, the dilator muscle is activated, that compresses the iris tissue and opens up the pupil. Everything else that is in here is blood vessels and trabecular structures, other nerve fibers. There's over 28,000 nerve endings in the iris itself. So again, when we're looking at this, this is sitting right here, and it's like we've taken a cross section. We've cut this iris right here so we can look at that cut edge. Okay, so as we look at this, we aren't seeing these cells wrap around. Sometimes we can actually see a little black edge in here. Sometimes we can't. This is a good opportunity to talk about when this pigment rough, these cells right here are stimulated by light. That's going to make the pupil constrict, and it's going to stretch out the iris tissue. When we don't have enough light stimulation here, it tells the dilator muscle to contract, which is going to compress this tissue, squish it in order to make the pupil bigger. Is that making sense? All right. We've also talked about, we want to talk about how the cornea actually sits above this. So we would have the cornea here with aqueous humor filling this gap. So the cornea is clear. When we see this kind of a white film, this is actually in the corneal tissue itself. What we also see with this is we see texture. So specifically, as these tissues compress, wrinkles will form. We will see wrinkles become visible, is a better way to put this, because these wrinkles actually formed when this person was gestating. And so we will see contraction furrows in here. The sphincter muscle and the dilator muscle. So again, the sphincter muscle goes around and around. As that muscle contracts, those fibers ratchet in and it gets smaller. Now, how does that then open up again? Because it has to open up at some time. The edge of that sphincter muscle is anchored into the edge of the dilator muscle. So these two muscles are connected right here. The outer edge of the dilator muscle is anchored into the sclera. So that means when this dilator muscle contracts, the only thing that can happen is this edge has to move outward. And as it's moving outward, it's compressing iris tissue and it's pulling on the edge of the sphincter muscle, which is going to force the sphincter muscle to open. Okay, does that help? Does that make sense? Does that make sense? All right, Josiane is saying yes, fantastic. All right. So what we see this eye, can you see that right here, the tissue changes color? We've got basically one color of tissue here, and then it changes color here. Can you see that? If you can, give me the word change in the comments box. If you can see that there's a different density, a different color here versus here, fantastic. Sherry and Chana, lots of change, fantastic. So this area here is precisely that constrictor muscle. Precisely that constrictor muscle. That dilator muscle then reaches right into this edge. So again, when this inner edge of the pupil is stimulated by light, it's going to force this constrictor muscle to ratchet down. All right, when we don't have enough light, that's going to force this dilator muscle to constrict, which is going to stretch out the pupil again. So when we can see the edge of this clearly, it tells us that there is a layer of trabecular fiber missing. We shouldn't be able to see this edge if there was enough layers of fiber here. When we have layers of fiber missing, it means we have a reduced integrity, a reduced strength and resiliency to that part of the body, to the corresponding part of the body. So that fiber structure that we've talked about is actually made up of capillaries that are coated with collagen. And those capillaries, as you know from your anatomy and physiology, capillaries have an arterial flow and a venous flow. The arterial flow is always taking the blood away from the heart. The venous flow is always taking the blood back to the heart. The same is absolutely true in the iris. So the arterial blood always starts at the limbus or the edge of the iris and moves towards this ring here. We call this the collarette. And the venous flow always moves the blood away from the collarette back to the limbus. When we're looking in this zone of the eye, the blood flow starts at the inner limbus or that inner pupillary edge, goes towards that ring, and then the arterial flow goes that way and the venous flow comes back out. So I just want to pop back here. So the arterial flow goes from here to here, and then the venous flow of blood goes out. The arterial flow starts here, comes to here, and then turns and becomes venous flow to come back to the inner pupillary border. Let's do a bit of a case study here. We're going to look at structure. We're going to look at a few other things with this. So this is a female in her mid-30s. She came to me with concerns about getting pregnant. She wanted to get pregnant and had had fertility issues for some years. They'd been trying to get pregnant for the last few years. She had conceived once and then miscarried. So the first thing I want to look at here is, do I see layers in her eye? And I do. We've got areas where the fibers are separated and I can see black in here. This black is shadow. I'm looking down into the iris tissue, right? And so where we see that we're looking down into the iris tissue, we know we lack integrity. There is a lack of resiliency, a lack of robustness there. Those areas are going to need a lot of support. They are not going to change their appearance, but we can still support them and improve how they function. So we've got lots of shading in here, this black and this on these darker colors. And we've got some shadow in here as well, which tells us some other areas that are not as resilient. So these eyes suggest, so this is her eye and this is a close-up of the same eye. This eye actually suggests that there might be a personal or family history of the MTHFR defect, which when you understand MTHFR has a huge impact on fertility. We also see the MTHFR gives us a suggestion that there might be some liver inefficiencies, and that can also compromise fertility. We don't often think of liver infertility, but again, when you know your A and P and you understand that the liver processes the carbs to make cholesterol, cholesterol is critical for making the reproductive hormones, you begin to understand how important liver function is with fertility. And we have contraction furrows, which again give us more information about how she burns through her B vitamins. We've got a bit of cloudiness towards the outer edge of her eye, which again suggests that she might have a liver enzyme issue that might be messing with her carbohydrate metabolism. And sometimes that will also show up as carb cravings. So knowing that she was trying to conceive, I asked her specifically, do you crave carbs? And she said, yes. Well, when I see carb cravings and the suggestion that she probably has MTHFR, I know where I need to head with her. Now, I don't need to talk about every single marking when I'm with her, because each and every one of these is not important to her goal of getting pregnant. So I don't need to belabor the issue at all. I just simply need to focus on what are the markings that teach me about why she probably is struggling with fertility. And when I understand those markings and when I understand her diet and her lifestyle, what kind of a program can I put together for her, right? It does not need to be difficult. So does that make sense? Do those pieces flow? If they do, give me the word flow in the chat box. Explaining the carbs, the liver, the carbs, does it all flow for you? Fantastic. Fantastic. Love it. Okay. All right, I'm just trying to see where I'm at. I'm sorry, I put these slides together a few years ago and I've used them periodically, and it's been a very hectic day. I haven't gone in to review these again. So if you want to learn more iridology, and this is out of date, I should have updated this. The next course is not starting January 12th, 2023, because that's in the past. The next course is actually starting on August 24th, coming up in just a week and a half. So if you're interested in that, you want to hop on to one of those calls. A little bit about what's included in the course, and then I think I've got some more eye slides after that. I hope I got more cases for you, because that would be fun. The course is 20 2.25 hour live webinar classes that are recorded for playback on demand. Each class cohort is limited to 10 students. Josiane is saying the course is online only. Yes, it is, specifically because to do 45 hours of iridology training in, let's say, 6 days is really intense. I prefer, and I think what you'll find if Jack wants to weigh in on this, what I find is that by doing the class 2.25 hours as a live interactive webinar, each week, it gives you time to practice and study and bring questions back to the next class, right? And most of my students say by the time we get halfway through the course, they can't imagine doing this in a live face-to-face setting. In the format of the class, we unlock, you have your mic open and your camera on, so we actually have some give and take with you and the other students. Jack says this was more than enough time for class. Any more would have been overwhelming. Yeah. Exactly why I've done it this way. And with doing it live, the class sessions are recorded, so you can have playback on demand. Live group mentoring twice each month via webinar. We have 2 live group mentoring sessions over Zoom where you can bring questions you've got, cases you're working on. We talk about business development. We talk about all kinds of things, anything related to your iridology business. And Jack has said Judith was always willing and able to answer any questions you may have. Love that. She knows how much I love questions, actually. My goal here is not just to teach you to identify markings, it's to teach you how to use iridology and how to use it successfully in a business. We have the student and alumni MeWe group. So we're not on Facebook for my student and alumni group, because Facebook likes to censor what we say. Right, so we moved it to MeWe where we can speak freely. And this is another place, another way to ask questions, whether you're in class or whether you finished your class. Like Jack is still active in the MeWe group and she's certified and active. You receive a 225-page digital textbook that you download. You can print up a copy if you'd like. 45 pages of cheat sheets that are digital. You download them again if you want, or just store them on your computer. Now, if you want to certify, My curriculum meets the requirements for the International Iridology Practitioners Association, and my course prepares you and contains all the mentoring steps to prepare you for certification should you wish to do that. And I walk you through that process. I hold your hand and make sure you get what you need to hopefully pass the certification process on your first attempt. Oh, I guess I don't have any more cases here. And that's an outdated slide. I was sure I had updated these. Okay, I want to do another case. Who wants to do another case? If you want to do another case, Megan, this course is level 1 and level 2 combined. Level 1 and level 2 combined. And I specifically did that because I wanted to rearrange the material and put it into an order that made sense, so that we build logically and sequentially from one week to the next. Okay, so let me grab some iridology photos here. Who will be my unsuspecting? Because everyone's saying yes, please, another one. Okay, so we're really focusing mostly on structure. And what I want to do is I want to get him just give me a second. I'm looking through my file. Okay, Chana, good question. Just let me find this. That's his name. Took me a minute to remember this client's name. He's given me permission to talk about him behind his back. So let me grab this and do a new screen share. Stop share. Let's do a new screen share to come here. Okay, so Chana is asking, what is the exam? The exam is a 3-part exam. The first part of the exam is, now I've lost my chat box. Let me just grab that again. There we go. The 3-part. The first one is you do 10 case studies. I provide you with iris photos and information. You write them up in a particular way. You send them to me. I mark them. We review them together. If there's anything that I need to reteach or just tell you, you did a great job. Then IPA gives me another case to give to you. You do it up. You send it back to me. I mark it. You and I meet again. We go over that, make sure everything is rock solid. The third part then is you do the IPA exam. It's a 240 multiple choice question exam administered online, and it is time limited, 4 hours, and you need to get 80% on it to pass. And you can, once you're doing the exam, if there's some questions you're not clear on, you can flag those and go back and check them out. It is open book. I want my students to be solid enough that they can complete the exam in 2 hours and still have 2 hours left to look up any questions they have. The course is always online. You schedule it at your convenience. So it's not a set time that everybody writes it. If you've finished the course and you've done all of your case studies and you're ready to rock for the exam, you purchase the exam. There's a few other little steps in there that I walk you through, and you tell them when you want to do that, and they will send you the link at the appropriate time for you to do the exam. Okay. All right. So this is a fellow in his late 70s, came to me actually wanting to lose weight. Now, I don't do weight loss. I refuse to do strictly weight loss programs because I think that it's more important to do a health program, a health improving program. So in conversation with this fellow, he had had prostate cancer, was doing hormone therapy for that. He had had some venous ablations done. He was on like 5 or 6 different blood pressure and heart and cholesterol medications, and had a really awful diet, was not active, really needed to get some things done. And so I told him, I won't do weight loss with you, but I will do health improvement with you. And it will involve diet, and it will involve activity, and it will involve supplements, and we will get you to where you want to go. And so he kind of went, "Oh, well, all right then." I think he was expecting a magic bullet. What we see here is he has the lipemic diathesis, which suggests that he may be plaquing arteries. This is in the cornea. This is a bit of a very, very thick scar tissue in his eyes. I'm not sure exactly what it is. We see that his digestive system is not robust. We see that he's got lots of different areas that tend to want to be a little bit less resilient. Jack says pterygium. I don't think this is a pterygium, but it looks like he's trying to set up a pterygium here. He is definitely hydrogenoid, which says lymphatic system doesn't want to be healthy and strong. Circulation's not great either. He's got a circulatory ring. We've got gray patches. This is going into level 3 that again talk about circulatory compromise. So, just looking at that and looking at just the shading even in this area. Very first place we started was to get rid of his rice cakes and marmalade that he was having for breakfast and replace it with eggs and vegetables. Right? At first he looked at me and said, "You want me to have vegetables for breakfast?" I said, "Yeah, I'm suggesting that that would be a good idea." "Well, all right, I'll give it a try." A week later, I get an email saying, "If anyone had ever told me I would like vegetables for breakfast, I'd have told them they're crazy. So I can't tell them that. I can't tell them that now because I really like vegetables for breakfast." So that was cool. That was cool. He had joint pain, which made it difficult to walk. And so we got him doing vegetables. We got him doing protein 3 times a day. His hemoglobin A1C was elevated. His cholesterol was elevated, as was his triglycerides. But we started working on the diet. And we absolutely got him to start walking. I knew I couldn't get him to go for long walks because his knees, his ankles hurt, right? So I said, "Could you just go for a 5-minute walk after each meal?" He thought he could do that. So we started working with him, and just want to come around to his other eye. There we go. It tells pretty much the same story exactly. We got him doing that. We got him using some digestive enzymes. We got him increasing his vegetables. We got him increasing his protein. We reduced his refined carbohydrates. His weakness is wine. He and his partner really enjoy wine. And so I said, "Well, you can have wine, like 2 glasses a week, but you can't have it every day. You can't have half a bottle a day because it's going to ruin your cholesterol, your triglycerides. It's going to get in the way of what we're doing." So he, "All right, okay." And so he grumbled his way through that, but he did it. And after about 6 months, he had lost about 20 pounds by increasing his protein, increasing his vegetables, reducing his wine. And he was to the point where he was walking for 45 minutes to an hour every day. His joints did not hurt. He came in and he said to me, "You know what? This is great." And I said, "Why?" And he said, "Because I'm wearing pants I haven't worn in years. And my joints don't hurt. I feel so good." Jack's saying, "Did she see a fermentation sign in the sclera?" Yeah, we've got fermentation here as well. Right. So, he's just loaded with it. We've even got a pinguecula here, which again is another liver indicator. Right. So we've got lots of things here that were telling us that what we needed to do. I want to share another client's eyes with you because this is a really exciting case, and it's not so much structural. It's just a really good case. Okay, let me stop this share and let's grab a new share. Okay, I've lost my control panel. There it is. Screen share here. Okay. This is a fellow who, let's make sure we've got that up. There we go. And not the best picture. We'll look at some more of his eyes. he's been a client of mine for, off and on for about 8 years. And, he'll come in for a few appointments, then he'll fade off. When he finally started coming back in again a year ago, this time he was motivated. The other times it was, yeah, my wife said I should be here. Yeah, sure, I'd like to lose a few pounds, yada, yada, whatever. He wasn't really motivated. So this time he came in because he was now on 5 medications. He had elevated hemoglobin A1C, elevated cholesterol, elevated triglycerides, elevated blood pressure, and it was taking 5 meds to bring his lab values into a normal range. He said, what do I need to do? And I said, well, you need to work hard. I'm gonna kind of kick you in the butt. We're gonna get this thing done. You can see the beginning of a lipemic diathesis here. We can see that he doesn't digest his proteins very well. We can see that he holds on to, has a tendency to want to hold on to a lot of garbage in his intestinal tract, right? We can see that he burns through his B vitamins pretty quickly. And those B vitamins are key for the liver, and the liver needs those B vitamins to metabolize the carbs so that you can make the healthy cholesterol and so that your liver can denature the other things it's trying to get rid of, right? So we've got all of these things that need to happen here, but his diet is garbage, right? Again, it's bread and sugar and donuts and chocolate bars and a few vegetables if he has to. And so we start talking about what his diet needs to be like, and we start cleaning it up. We start getting him to go for walks every day. I start people on walks because if I tell them to buy a gym membership, they're probably not going to do it, right? But most people can walk. Where I live in the winter, where it's -40, you're not going to walk outside. You're probably going to go to a shopping center and walk indoors, or buy an expensive gym membership and walk around the oval, the running oval. But we got him to start doing things. And the funny thing was, he came in, his wife has been a client of mine for 25 years. It made her start to come in. As he started to fix his diet, she got on the bandwagon and started to fix her diet, which was very cool to see that he was now poking his wife to do better. And they started doing things together. So we see suggestions here that he's congesting circulation. And this suggests an increased risk heading towards possibly a stroke at some time in the future. We don't want that, right? We see, again, we've got an encapsulation. His body's holding on to some kind of a virus or bacteria, a little bit of fermentation here. Then we go to his other eye, and it's very much the same story, where we're seeing, again, the lipemic diathesis, liver not wanting to do its job very well. And this being the right eye, we've got a fiber coming down through the right liver zone, which says, yeah, I want to be in trouble there. We've got some fibers going sideways through the liver zone over here as well. So there's some indications that he could want to get into some trouble along the way. We've got less resiliency in his lungs and in his heart. Well, cholesterol and blood pressure and things like that. We need to deal with this because I think he's in his early 60s, late 50s, early 60s. So what did we do? We started cleaning up the diet. We got him off the refined carbs. We got him walking daily and doing resistance training. He works as a security guard. So half of his shifts, he's in the computer center, watching the computer screens. The other half, he's walking the perimeter. So I said, well, when you're in the computer area, can you have stretchy bands? Could you be doing some stretchy band resistance exercise while you're watching the computer monitors? And then the other days you're out walking the perimeter and you're walking it at a fairly good pace. Is that possible? It was. He could do that. So again, we see lots of predisposition towards congestion in here that we don't want to be seeing. And we got him working with this, and he's on really good terms with his doctor. So cleaned up the diet, got him being more physically active, introduced some appropriate supplements. He went to his doctor at the 6-month mark. They ran labs, and the doctor went, well, I don't know what you're doing, but we are taking you off of this one medication. I think the first one to go was the glucophage, the metformin drug. That was cool. He went for his 12-month checkup just a couple months ago, and be darned if his cholesterol and triglycerides are not almost completely normal and his blood pressure is coming down. So the doctor says, you know what, we're going to take you off the 2 cholesterol medications now. So then he said, you know, if you keep this up, it's going to be the case that we'll be taking away the blood pressure medications the next time I meet with you. And so they're hoping that in the next 6 months, everything he's done will have done such a good job of cleaning things up that he'll come off those blood pressure meds. Now, when was the last time you heard of someone doing their homework well enough that they could come off cholesterol, blood pressure, and blood sugar meds? Right? He's worked hard. He's earned the right to come off those. He's earning back his health. And he says things like, my energy is so good. He's given up coffee. He does not need caffeine for energy. Right? He talks about having energy to do things, about feeling more fit, about feeling good. That's, you know, seeing these things in his eyes gave us the direction we needed. We knew we needed to support his digestion. We know, and we need to make sure his bowels are working well, because if your bowels don't work well, you start reabsorbing that material. And as you reabsorb all of that toxicity, your body will actually make fats that it will take that toxicity and store it in the fat cells and make them bigger, right? That'll put weight on you. And so all of these things tie in together. And his eyes were what guided the questions I needed to ask. And they're what guided the program formation for him. Does that make sense? Yeah, it helps us to personalize the nutrition. That's a really good way of putting it, Jack, a really good way. Yeah, and so I want to know, did that make sense? Yeah. Fantastic. This is so good, so good. So when we're looking at eyes, yes, we have to understand the structure. We have to understand what we're looking at. We have to understand why the structures are the way they are. And what we need to do with that then is use that to guide that with the client's symptoms, to guide the questions we need to ask to help us get the better information so we can then create the most effective protocol. Rarely do I ever give a clean sweep protocol in one appointment. I like to build protocols step by step because I want my clients creating lifelong habits that they can stick with, that will get them long-term results. So important. I could have given this client everything he needed to know in one appointment. It would have been a 2.5-hour appointment, and he would have had it all, but he would have walked away really overwhelmed. And that would have meant that he wouldn't have been able to follow through. So I like to do it in bite-sized steps. Now, a couple of key diet changes here, introduce a supplement. Next appointment, a couple of key diet changes to add on, and now let's get you being physically active. Next appointment, little more dietary tweaking. Here's another supplement that will be helpful to the process. And we build it over time, over 4 to 6 appointments, to get the client where they need to be, but in a way where they can achieve it and be really successful. So we need to know the anatomy of the eye. We also need to understand full body anatomy and physiology so that we can put it all together. Fantastic. So love that there were questions that came in and we've addressed them as they came up. And I love that you played with me in my sandbox there. Thank you for that. Any other questions that are relevant to the topic? Fantastic. All right, we are golden. That is all I have for you today. Thank you so much for being with me. Really appreciate it. I look forward to seeing you next week, and probably different day, different time. China's saying, why would there be a brown ring around the pupil? That teaches us about the resiliency of that area of the body, of the corresponding body part, right? So it depends on what the base eye color is before we actually know what that is going to mean. We have to integrate the markings with the eye. And so again, we would need far more information. A blue eye is going to say lowered resiliency, but again, it'll tell us about organ involvement. What other organs are affecting the digestion or affecting that organ? Yeah, it's always about the interaction of things, always. All right, so again, thank you for being with me today. Those of you who have the anatomy and physiology under your belt already, if you are interested in learning more about the dynamic iridology class, use that link that we mentioned at the outset. And let me just pull up this screen share. Ignore the date on this slide because it's wrong. Can't believe I thought I fixed that. But this link, tinyurl.com/dynamic-iridology-insight, will allow you to set up a time to chat with me over Zoom so we can talk about your goals, what you want to accomplish with iridology, and talk about the course to see if the course is a good fit for you. I look forward to speaking with you really soon. Take care. Have a good week. Bye for now.